Welcome to the RheumNow podcast. It's the 1st of February, 2019. I'm Jack Cush, executive editor of RheumNow.com. What happens when pirates get scurvy? Arr. What happens when women with autoimmune disease get mechanics' hands? What are they doing under the car? And lastly, what happens when RA patients get periodontal disease? We're going to cover that today. Our first report is on scurvy, and it comes from MMWR and the CDC, where they have an interesting report of an outbreak of scurvy in the Sudanese in Africa. And obviously this is related to diet, nutrition, poor health conditions in that environment. And I bring it up because it's a reminder that scurvy is still a public health problem around the world. It's still a problem here in the United States. I had a great case to present as outsmart the panel kind of thing last year of scurvy that my partner, Dr. Dow, diagnosed in a woman who had GI complaints and gingival complaints and joint complaints and elevated set rate and CRP, and her husband ratted her out and said she had the world's worst diet. She ate chicken McNuggets and gummy bears and nothing else. And sure enough, she had no vitamin C and she had scurvy. Well, I presented this to a panel only to get upstaged by a pediatrician who presented 3 cases of scurvy to the panel as well. And yet, even though they had been primed and educated on scurvy, and then when I presented my case of scurvy, nobody got it, suggesting that it's hard to identify these people, but you have to think about it. It's very common in younger people, adolescents, young adults, who have these horrid diets, like I said, only chicken McNuggets or only the sort of monotonous diets, or a fad diet gone wrong, obviously with no vegetables and no fruits. But you should look for the symptoms, and they're often musculoskeletal with mucosal and bleeding and gingival kind of things. So arthralgias, frank arthritis and synovitis, lethargy, fatigue, gingival pain and bleeding, gingival hyperplasia. They have some skin lesions. They can get chest pain. They can get purpura in their skin. They have poor wound healing. They may have deep myalgic and bone kinds of pain, and they can even have elevated sed rates and CRPs. So you should look for these. They're not that uncommon. Scurvy, yes, in your backyard. So an interesting study looked at 576 patients with autoimmune disease and tried to identify the frequency of mechanics' hands. Now, mechanics' hands, as you know, is sort of a roughened, scaly, hyperkeratotic digital lesion that has been linked mostly with the antisynthetase syndrome and the inflammatory myopathies. However, in this particular cohort, almost 600 patients, 17% of patients had mechanics' hands. They were mostly seen in, guess what? Wrong. MCTD, 50% of patients came from MCTD, 35% came from dermatomyositis, 15% came from primary systemic sclerosis, 15% from undifferentiated disease, and 14% from Sjogren's. None with lupus had these mechanic hands. So that means UCTD and MCTD. I like UCTD as a diagnosis instead of MCTD. MCTD, I think, is a diagnosis on its way to something else unified by an RNP antibody. So that makes up 2/3 of patients with mechanics' hands. So these mechanic hands patients, they were very, very likely to have abnormal nail fold capillaroscopy. They were more likely to have RheumNows. They were more likely to be JO1 positive. And again, as I said, abnormal capillaroscopy. So it's interesting to note that the range there is different than what you might have normally have been taught being related to dermatomyositis, polymyositis. A UK cohort study looked at patients with hemochromatosis, specifically the ones who had HFE gene rearrangement testings, looking for the C29A2Y mutation. They found that when patients were homozygous for that mutation, and you looked at men with that, the odds of actually having hemochromatosis went up like 411-fold, the odds ratio 411. Patients with that rearrangement and who are homozygous were likely to have not just hemochromatosis, but liver disease, RA, osteoarthritis, and diabetes, a 2 to 3 to 4-fold increased risk of those. So the purpose of the study was to look at, if you have the gene and you're thought to have hemochromatosis, what other diseases co-associate with this, and RA, diabetes, OA, and obviously the liver disease. The much more common, of course, was those who had these heterozygous mutations for the HFE gene, and they were way more common, but they were also less likely to be symptomatic, and actually they had very modest amounts of morbidity, which was very different than those who were homozygous. An interesting study looks at the association between periodontal disease and rheumatoid arthritis. Now, we've heard this story before. I'll just give you some numbers. 187 RA patients, 157 without RA or inflammatory disease. When periodontitis was present, the adjusted odds ratio of having periodontal disease, if you had RA, was 20-fold higher. The presence of periodontal disease, inflammation, and what looks like infection, but it's really just inflammation, also was significantly associated with RA disease activity. What I'm looking to see, and I haven't yet found, is show me someone who treats the periodontal disease and their RA gets better. Or show me someone who treats the RA and their periodontal disease goes away. There's some hints of that out there. These are causative associations. They actually have a very similar, the pathology, the biology, the cytokine profile of the synovium and the joint is almost the same as the periodontal tissues. And is this a microbiome issue, or is there truly a good link here? We need some more cause and effect studies, I think. A study of almost 750,000 patients in southern Sweden shows that almost a quarter of the osteoarthritis patients in southern Sweden are using opioids. And it's basically twofold higher than those who don't have hip or knee osteoarthritis, suggesting that even outside the United States, this is a big issue. And the question is, do they need it? We do know there are plenty of studies that show that opioids are no better than simple analgesics like acetaminophen or even low-dose Tylenol. And then other studies, not related to opioids, but showing that turmeric is as good as ibuprofen in managing osteoarthritis, suggesting that sometimes the frustration of managing those patients, especially near the end, is riddled with the use of opioids, which comes with a new risk and a higher risk of things that you may not want to exhibit put upon your patients. An interesting study of 100 kids with Takayasu's finds that there's a 3% mortality in the first year of that disease. It's low, but it's not totally unnoticeable. There is a 50% chance of significant morbidity in the first 5 years. So these patients can be sick, they can be hard to manage. In their cohort, kids, of course, 14 years of age was the mean age. 3/4 of them were females. Things to look for: hypertension, blood pressure discrepancy between the limbs, bruits in 50%, hypertension 70%, pulse deficits in 38%. The artery involvement that was found in the kids: renal arteries in 2/3, aorta in 43%, subclavian 44%, carotid in 43%. That's the profile of the ugly but easy to treat Takayasu syndrome. You got to make the diagnosis though. Yesterday's New England Journal article on oral or IV antibiotics for bone and joint infections. A 23-24 multi-center UK study looked at almost 1,000 patients who, after they had their surgery or the initiation of antibiotics, were followed and specifically looked at whether they were treated with IV antibiotics for 6 weeks or oral antibiotics for 6 weeks. There's not a lot of breakdown here on types of infections, the types of antibiotics. This is meant to be a non-inferiority study, and guess what? You're looking out at 1 year, and the outcomes at 1 year. The failure rates were exactly the same between the IV group, almost 15%, 14.6, and the oral group, 13.2. Those are not significant differences, suggesting that I think the dictum that patients should get IV antibiotics for 6 weeks has been challenged by this cohort study. I do think we need more studies to be totally comfortable using oral antibiotic therapy as long-term therapy after a bone or joint infection. There's an interesting article that we posted from MedPage today about the risk of inflammatory bowel disease in secukinumab patients. It's sort of a meta-analysis of their 7,300 patients with either psoriasis, psoriatic arthritis, or ankylosing spondylitis, showing that the event rate for IBD is with secukinumab is basically about 2 per 1,000 and 0.2 per 100 patient years, looking at almost 96,000 patient years of experience. As you know, the numbers tend to be a little bit lower there for psoriasis, tend to be a little bit higher for ankylosing spondylitis. These are very rare events. There are a few cases in which patients had pre-existing inflammatory bowel disease who received the IL-17 inhibitor and did have some flares. But again, I ask patients if they have an inflammatory bowel disease, but I would not defray useful therapy because of an incredibly low risk. I mean, we give biologics all the time with an even higher risk of developing an SIE, a serious infectious event. So those are the real numbers, and you can find them on the website. A study from the ASBMR, the American Society for Bone and Mineral Research, was a task force that was challenged with finding out what the actual benefit was to these vertebral augmentation procedures. We're talking specifically about balloon kyphoplasty and cement vertebroplasty. And in the end, looking at the analyses and the data out there shows that these are not any better than placebo with regard to reduction in pain. This is a little bit of a shocker because I don't know about you, I do see patients with vertebral collapse and acute pain from that. And the idea is that if you can show a relatively new onset vertebral compression fracture, one of these procedures may provide significant benefit with regard to pain and long-term pain, and I've seen that happen. But this analysis of controlled data suggests it may not be happen. I think that we're going to now maybe be a little bit more cautious about using these, especially in patients who you know not to have or you can't be certain as to the acuteness of the fracture. And I think you're going to have to talk to the experts that do these procedures at your center about this data and how it's going to affect your practice. Lastly, we have a report in yesterday's or today's RheumNow about an update on pregnancy. There was one about infertility and some disappointment there. I'll just tell you the data about the second report, which comes from the Otis registry, where they followed 490 women, mostly with RA, almost 100 with JIA, and looked at whether they discontinued the TNF inhibitor once they became pregnant. A quarter of this cohort discontinued a TNF inhibitor before week 20, 41% used the TNF inhibitor beyond week 20, and 34% did not use the TNF inhibitor at all during pregnancy. They showed that stopping the drug before week 20 was not associated with any worsening or a significant worsening compared to the other two groups of their inflammatory arthritis. Of course, it's incredibly important to keep the inflammatory arthritis under control to have the best possible outcomes for the fetus and the baby. They didn't report about birth outcomes in a study, although they did collect the data. I assume it's going to be part of another study. But the idea is that once patients do get pregnant, they could, in fact, stop their TNF inhibitor. One of the problems in this particular study is at enrollment, disease activity was low to minimal in like 72 or 73% of patients. That's pretty high compared to most cohort studies looking at pregnancy. So yes, it makes sense if patients are doing very, very well and are well controlled at the time they achieve pregnancy, it makes sense to stop the biologic. However, it does not make sense to stop the biologic if they have active inflammatory disease, because we know they can continue to take, especially the TNF inhibitors, throughout the pregnancy and do very well as far as the maternal and the fetal outcomes that are not going to be affected by TNF inhibitors. That's it for this week at RheumNow. Make sure you can go to the website and click on these links and read a little more. We'll see you next week on the RheumNow podcast. Tell your friends to sign up and give us a good ranking on iTunes.